Hello, my name is Claire Harrison from London in the UK, and I'm delighted to be here at the third iwMDS MPN in Lisbon with three fantastic colleagues, and we're going to discuss rare and challenging scenarios in MPN and a session that we just had, which was very lively and produced lots of practical advice and lots of bang-up-to-date data. So I'm going to ask my colleagues to introduce themselves, starting with you, Andreas.
Yeah, my name is Andreas Reiter. I am a hematologist from Mannheim in Germany.
Hi, my name is Deepti Radia. I'm a haematology consultant at Guy's and St Thomas' Hospital in London.
My name is Nicola Polverelli. I am a transplant physician at the Fondazione IRCCS, Policlinico San Matteo in Pavia, Italy.
So let's start with you, Nicola, because you've produced some really important data concerning some of the very rare and atypical variants of MPN and thinking about, the definitive but risky treatment of transplantation and how to guide colleagues towards that. So summarising that in 10 minutes is a challenge, but what would your messages be in less than 10 minutes for this panel discussion?
Yeah, as I said during the discussion, the first aim of this presentation was to increase disease awareness, because we are talking about very rare condition, and often we have a center with a limited experience managing such patient, and therefore referring early such very rare and complicated cases to a transplant unit is fundamental to assure a smoother transplant journey for such a rare but aggressive condition. So during my presentation, I tried to manage all this stuff in just 10 minutes. It was quite complicated, but at the end, I hope that the audience enjoy the session.
We definitely did. I mean, I think this is a big challenge, isn't it? And your point about assembling a team for these rare entities, and especially also in a field which is really pretty fast moving and where there's more and more data, is so important. And that was really well exemplified by both you, Deepti, and Andreas in the field of, mastocytosis, eosinophilia, and understanding all of these molecular markers and how that plays into management. You really need to have a multidisciplinary team, but experts in all of these different fields, I think.
Yeah, multidisciplinarity is the key. I mean, in current days, we need to integrate each experience in order to ensure the right positioning of the transplant in every disease, and this is particularly relevant for such rare conditions where a lot of different physicians coming to allergologists, for instance, are really important to manage the patient before the transplantation and even after. So, and we have a lot of therapeutic options also to deliver before, during, and after transplantation. So we have to be flexible, some way to discuss the patient with other specialists, experts in the field.
Absolutely, and some of these entities can have a really quite benign and long course, and some can be very aggressive. And I'm just thinking about the presentation you did, Andreas, and all of your work in really defining some of these very rare fusion genes, outcomes with novel therapies, and then, the patients where you can treat with a novel therapy, we're always tempted to do that, but when you should really be thinking about transplantation. Any key summaries from you?
Well, I would say, when you present all the data in 10 minutes, it all looks quite straightforward. You do molecular testing, you do this or do that, and you have these or this recommendation. But I think one of the main problem is, number one, for example, for eosinophilia, I would say that the patient's history of eosinophilia is probably median more than 2 years. I've seen many patients, with a 2 to 3, 5 years history of eosinophilia symptoms, and they are somehow lost in the network, so they are seeing the pneumologist, maybe the allergologist, and so now that has really changed about 20 years ago with the first identification of this FIP1L1 PDGFR fusion gene. And so now everybody is testing the patient for this fusion gene, but then it stops. So, and meanwhile, it has really become, as you could see, very much more complicated. So we have other fusion genes, and many of them, which I did not have the time to also present that, sometimes are very complicated to find. I mean, we really have to use different approaches of molecular genetics. I mean, up to whole genome sequencing sometimes, and if you really think there's a fusion gene. And then I also wanted to highlight the point mutations. I mean, this is something, other disciplines are not doing at all, and we even find JAK2 V6F mutations in some of the patients. And I mean, the most important mutation beside FIP1, iwM, PDGFR is definitely KIT, D816V. This is associated with systemic mastocytosis, and this is also, I think, a very nice link then to the presentation of Deepti. And I think my major point of my presentation is that, I mean, it's sometimes difficult to detect the fusion gene, but the main message is that you should not miss, a targetable molecular lesion. And then I always have to discuss with doctors, should I do these extensive investigations? But I have to say, when we think about the expensive treatment, I mean, we shouldn't really talk about that. So, and I think in some of these patients, really, whole genome sequencing at the end is really necessary to find these molecular aberrations.
Yeah. And as I'm thinking about the field, just coming to you now, Deepti, and thinking about finding these point mutations. You mentioned JAK2, and there'll be a lot of discussion about JAK2 V617F, and it's more than 20 years old now in this meeting. But the c-KIT mutations and mastocytosis, aggressive, indolent, but also those patients with overlaps. I mean, that's where we've really seen huge impact.
I think it's been revolutionary for the patients within the SM arena, and also spilling over into what we do with transplantation moving forward for those with very advanced disease. And I think we've been lucky in this field to find for the indolent patients a drug and a targetable mutation that makes a difference. Again, talking about how many of those patients really need to have this is the next bit of work to be done in terms of quality of life. And in the advanced arena, I think if they have that, they've got a better outcome. Talking about transplant in a better remission like we did with the CNLs, the better they are from an SM point of view in these advanced diseases, the better their transplant and a possible potential cure might be as a result of that point mutation.
If I can add, I mean, if you see a patient, let me say, with 2,000 eosinophils, I mean, the problem is really at the end of all we are doing in diagnostic procedures, it can end up with watch and wait, but it can also end up with a very strong referral for allogeneic stem cell transplantation. So we have the whole gap of treatment decisions. So, and we have to work very hard to get to this point to make really the right decision for the patient.
Mm. And I think more and more it leads to, really finding your expert and assembling your team and understand what you're dealing with. But I just wanted to come back to mastocytosis and ask a question about avapritinib. I mean, your group, Andreas, presented that beautiful data with revised prognostic scores and showing that avapritinib, patients do better, but the patients who are really struggling are those with also an additional hematological malignancy. Do you think the next step is to do avapritinib plus targeting those other things? I'm just asking both of you, actually.
No, I mean, this has now really become the hot topic, and this is just the next step. So we first had to find and to use a new drug, and I think, in my experience, for many of these diseases, really the use and the efficacy of drugs has then shown that it is even more complicated. And now we have found this issue that avapritinib can really produce, or patients can achieve very durable remissions on the mast cell compartment. But this AHN, it may be driven by KIT D816V, but it may be driven also by additional mutations. It may be driven by additional mutations alone. So now we have a completely new field again on molecular genetics, maybe even with something like single cell sequencing when it becomes so that you really have to decide what is going on in the AHN. And then, it's getting more complicated, but then again, to make the right decision. Is this a patient for avapritinib alone, for avapritinib plus something else, which still needs to be defined? Probably a drug like azacitidine. I always say, please do not forget cladribine. It's also an effective drug, so it could also be. And then at the end, to make the decision on whether and when I perform the allogeneic stem cell transplantation, because this is another really hot topic now. Should I perform the transplant, I mean, at least in my view, at time of best remission? Or should I wait very long for the efficacy? Should I wait, for signs of relapse and then to go for transplant? So again, there's still a lot to do.
I think we've got this seesaw, haven't we, with the mutational landscape, and we're learning a lot more about it. And at some point, I think possibly combination therapy to balance out that seesaw, depending on where they are to move to transplant, which might be the only curative option. And the only reason we've got here is we've had a drug that produces complete remissions in up to 30% of patients, allowing us to look at the rest of the mutational landscape. So the more we've done, the more we've unearthed. But combination treatment with transplant for those that are eligible is the only cure, really.
Yeah, patient journey is becoming even
a lot more complicated.
More complicated thanks to the diagnostic, to the therapeutics. And I would say not at the end to consider transplantation, but at the very beginning, we discuss with our team to investigate the role of transplant for that specific patient. And even if the patient has not a substantial indication for transplant, at that time we strictly follow the patient during the follow-up to detect the right time point for a transplant indication. That's the way I think we should manage such patients.
Absolutely fantastic. Well, thank you all very much. Thank you for your contributions to the meeting. Absolutely excellent discussion, so much more to learn, but good to have your team assembled.
Yeah, exactly.
Thank you.
Thank you.
Thank you very much.
Yes, thank you very much.